First of all, I'd like to thank Clodagh, Mary and the All-Ireland Institute for inviting me to speak to you all today. It's a great opportunity for me. I'm going to talk today about quality in palliative care and its evolution really over the last, let's say maybe 15, 20 years, and my experience of dealing with it during that time as my own kind of career evolved. So I'm just going to start with a quote from Steve Jobs, and he said, "You can't connect the dots looking forward, you can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future." And I find this quite impactful because it relates to me, the question of how I'm even here talking to you all today about quality. Because I mean, when I was in school, I never had any interest in management or business or quality or any of those things. I never did, finance or accounting. I studied science and I did medicine. And then I was very much an A plus B equals C type of person. And I qualified in 1996, and then I went on and I did a medical scheme, and my career sort of just evolved from there, as it does. Now, as a young doctor, as many young healthcare professionals are, I was, in my registrar years, I was very much focused on patient care. So we were flat out in accident emergency and ward work, outpatients departments, night work, on call, all of that stuff. Now, in relation to quality, we did a large number of audits as we went along to tick boxes, but we weren't quite sure where they all went, or what standards were, or where they actually came for, or what they really did. But one thing was for sure is that the doctors and nurses, like all allied healthcare professionals, we were stuck to the pin of our collar at the time, and we were really worked to our limits. So I took up a representative role with the Irish Medical Organization. I found that initially when I went to meetings with management, there was kind of, I felt anyway at the time, there was a significant disconnect between management and clinicians. We were all moving in the same direction. We all wanted the same things, but we seemed to be talking in a kind of a different language, or something that I now call management speak. So things like governance, KPIs, key performance indicators, minimum data sets, performance metrics, standards, outcomes, and really no one on the clinician side of the table had any idea what they were talking about. Now, in view of my own kind of ignorance, and I seem to, in my own view anyway, I seem to think that I knew less than anybody else. I decided to go off and actually kind of upskill, and I decided to do an executive MBA in UCD. Now, what executive basically means is that it wasn't healthcare. So the focus very much from day one was on leadership. It was on quality and metrics. It was on finance. It was on things like operations management, how to run things, change management, how to change things, strategic management, communication, business case development, resource applications, these types of things. Now, in the first couple of weeks when I was in the MBA, I was asked to actually do a business case presentation, something I'll never forget. So what a business case presentation was is that we went in front of the lecturers, and they sort of dissected the business case, which basically means that they ripped it to shreds. And I was asked to do one on healthcare provision, and I think it was kind of because they were trying to gauge where I was coming from, being a kind of a doctor doing an executive MBA. So I remember many times during that whole process saying to people that healthcare is not like business or aviation. It's more complex. And this was met with hysterical laughter from my colleagues doing the MBA, because they really felt that this guy hadn't got a clue what he was talking about. And they were actually right, as I found out. So they asked me a number of questions. They said, "Do you provide a service based on a skill set?" And I said, yes, doctors are very skilled. Do clients benefit or otherwise from it? And I said, well, we call them our patients, and yes, they certainly do. Are there outcomes? I said, of course there are outcomes. Are they measurable? Like, are they weller? Are they sicker? Are they better? Are they worse? Are they satisfied or are they dissatisfied? And I said, well, of course. So then they said, well, then it's exactly like aviation or any other service or business. And it can, and it really must be subject to continuous quality improvement. So I asked why. And so they told me that any service or any organization is always evolving either in a positive manner or in a negative manner. And if you're not actively engaged in continuous quality improvement in an evolving system, that means you're stagnant. which means you're far more likely to evolve in a negative manner than if you were actively involved in continuous quality improvement. Subsequent to that, I think it was around the mid-2000s when I started working in palliative care, I noticed, or I certainly felt, that we were very under-resourced. And looking back, we certainly were. If you look nowadays at the health budget in 2022, this is from the Department of Health, our overall health budget for this country is 21 billion euro. Now, we know that healthcare expenditure significantly increases towards the end of life. That's a given. But how this happens is actually quite complex. It depends on things like diagnosis, length of illness, functional status, social situation, clinical need, and place of care. And I know that Charles Norman, Peter May, and Bridget Johnson are doing very good work and very impactful work in relation to this as part of the TILDA project, and we're very much looking forward to the results of that. However, some studies internationally would say that up to 10% of health expenditure in any health system is for care in the last year of life. So that's quite significant. Now, in this country, palliative care receives approximately 109 million euro, for example, this year, and that's a half of 1% of the overall budget for healthcare in Ireland. Now, I don't think that's sufficient. I don't think it's reflective of the service that we provide. And I don't think it's reflective really of the model of care that we give either, because anywhere that this model of care has been implemented, it's been a cost-saving model of care. Now, I know that Peter May, Charles Norman, and Bridget Johnson have done a lot of work, and Nico Brick as well, in relation to the costings of palliative care and potential, cost-saving nature of it. And I think this is, again, very impactful research that has to be supported and really lauded, because it can really support our model of care. We've also done literature reviews in this country based on the evidence on cost and cost effectiveness of palliative care, and even economic evaluations to that end as well. And these all attest to the fact about the nature and the cost saving nature of the palliative care model. So at that time, to me, I remember thinking that, look, palliative care makes sense, and it certainly made sense to me then, and it makes sense now in terms of, from a patient care perspective, definitely, from a compassionate perspective, and then obviously from a cost perspective as well. So one day back in 2007, I was working in the daycare of a very well-established hospice in Ireland, and the patients were receiving really outstanding care. They were getting significant medical and nursing input, and physio and OT input, and social work input, and complementary therapies as well. So the patients were really benefiting from this. I could see people improving over their cycles of care. And on top of that, everybody there was in an upbeat mood and having a very good time, and the patients loved it. And the response of the service at the time was that it was closing the daycare for a day because they didn't have resources. So I talked to the CNM at the time, who was actually quite upset about it. And she said, look, they don't see what it is that we do. And as she was saying that to me, I was looking around at thousands of thank you letters in the actual office. I was talking to her. So at the time, palliative care made sense. I think it continues to make sense from a patient care perspective, a compassionate perspective, from a cost perspective, but also from a patient satisfaction and appreciation perspective as well. So I remember at the time, I felt that I was really stumped in a way, because I couldn't understand how we couldn't relay this to funding authorities and the powers to be about how good the palliative care model was. So it was around that time that I started looking at metrics, how to measure the outcomes that for patients. This was around 2007 when I started my SPR scheme. Now, if you want to understand where the term outcomes comes from, we have to look at the Avidas-Dunabedian model of quality in healthcare. It states that if you have the correct structures in place with the correct resources, and you have the correct processes of care, then you have the best chance of achieving the best outcomes for patients. Now, if you want to maximize this framework in a sustainable manner, then this has to be tied to a healthy culture in the organization, which is a function of good leadership, good teamwork, and I think a strong focus on MDT and healthcare professional well-being. I think only if all these things are in place can you produce the best outcomes for patients in a sustainable manner. So a little bit of quick info. When I'm talking about a tool, I'm talking about a group of outcome measures brought together to comprehensively assess a particular issue. So we have things like functional assessment tools, we have symptom assessment tools, we have quality of life assessment tools. And a validated tool is just a tool that's gone through the rigors of peer review. That's what a validated tool is really. Now, with many of them, with many validated tools, we have things like the support team assessment schedule, and following on from that, the very famous and very well validated and very good IPOS. We have the Edmonton symptom assessment scale and the brief pain inventory for assessing symptoms and pain. We have the Edmonton functional assessment tool, or the EFAT. We have the palliative performance scale. We have the Karnofsky's performance scale. We have the ECOG scale. We have the SCIP tool, the FAMCare 2 tool for measuring satisfaction with the service and the care. We have the hospital and anxiety and depression scale for measuring just that. And then we've the McGill quality of life questionnaire and many, many more. Now, when I was in SPR, I was actually working here in Milford. I remember seeing the Edmonton Symptom Assessment Scale, or the ESAS as it's called, and I really liked this. You know, I said, I'm going to introduce this into the unit. It made sense to me. It was very well validated and very well used, particularly in Canada. It was quick. It could be done on a daily basis and gave us this kind of nice, kind of graphical symptom trajectory that you can monitor patients with. So I met with staff and I explained why I thought this was a great idea. And I said, let's do this. So I gave 4 education sessions, and the result was an overwhelming failure. Excuse me. And I wanted to ask the question, why had this failed so miserably? So I did a mixed method study to evaluate this from the nurses. And what we found is that over a 3-month period, only 20% of patients had their ESAS scores completed every day for 3 days after admission, which is a very low completion rate. So the main issues identified by the staff is that there was insufficient education at the start and insufficient ongoing education during the project. The second thing was that it was too difficult to complete. The third thing was that the scale was too long. The fourth thing was that there were other more pressing commitments on the ward. The fifth thing was that there was a lack of leadership. I was deeply wounded and upsetting, hanged my head in shame. And most of the nurses felt that it was not clinically helpful, and 82% felt that it should not be reintroduced. So when I reflected on this, I felt that we had a large number of validated, strongly validated tools in palliative care. But what my study actually showed, and what my interactions with the staff and the nurses in the ward actually told me as well, is that I'd failed to implement an effective change management program when implementing this. That really stuck with me. So after this, I finished my SPR scheme, and I became involved in a group that developed the pharmacological management of cancer pain in adults. And this really exposed me for the first time, and I think many of our group, to the real rigorous evidence-based practice and international standards and recommendations for care. So we looked at things like the SIGN guidelines, the NICE guidelines, the American guidelines, Australian, New Zealand, European guidelines, all around cancer pain management. And we developed audit tools based on these standards. So that was a real, educating process for me. So if I want to look at the quality journey so far up to that stage, and I'm also updating it for just today as well. In 2001, we had the National Advisory Committee report on palliative care. So that's a seminal document from a policy perspective in this country. Since then, we've had a number of strong national publications and international publications in relation to the development of these things called key performance indicators. I'll talk about them in a second. We have the HICWA standards, the QA&I workbooks. We have the palliative care competency framework, the national guidelines, the metadata sheets for the key performance indicators in this country. We have the balanced scorecard for the minimum data sets, and we have a very strong model for palliative care, I think. So a lot of really, really good work has been done in the last 20 years in relation to this in this country. So during this time, we've had an enormous amount of outcome measures as well. So if you look at the international literature, I did a literature review of these a few years ago, and at that stage there was over 500 suggested outcome measures that were not validated in the literature. And I think since then there's been even more, but at some stage you just stop counting. I mean, there's just so many of them. So again, I'll come back to this. Now palliative care made sense and makes sense, I think, from a patient care perspective, a compassionate perspective, a cost perspective, a huge patient appreciation perspective. We have many validated tools, and there are an enormous amount of potential outcome measures out there. Yet I felt that we were still not reflecting the quality and the benefits of our model. And this was very much, I think, affecting our national funding, our service development, our recruitment and retention of staff, our portrayal in the media, our status within the healthcare sector, and ultimately it was affecting our patients. So I kept on searching, and really at that stage, I can genuinely say I wasn't searching for more information. I was trying to figure it out, how it could actually work. So in 2015, I was asked to become involved in developing key performance indicators for the HSE. Now, a key performance indicator, or a KPI, is a high-level process measure. It's not an outcome measure. So it's this thing here. And the clue about what it does is in the actual term itself, key performance indicator. So it's a process that we need to perform well to ensure the best possibility of a good outcome for our patients. And this is what national quality standards are mostly based on and should be based on. So I did that literature review where I found 500 metrics in the literature. And myself and Martina O'Reilly did a workshop with senior healthcare professionals. And then we did a Delphi process thereafter. And we settled on 5 KPIs that we all agreed on. Now, these weren't all adopted for various reasons, but 2 of them were. And as far as I can actually find out, these are the current national KPIs in Ireland. The first one is the percentage of patients referred to community palliative care seen within 7 days. The second one is the percentage of patients referred for inpatient palliative care admitted within 7 days. Now, I think that these both of these KPIs need to be maybe updated now at this stage. 2 of the ones that we actually introduced were the percentage of patients referred who are triaged within 1 working day. And the second one is the percentage of patients who have an MDT care plan within 5 working days. Now, we're also asked to submit minimum data sets. And these are more kind of output measures about numbers seen and the kind of the cancer diagnosis or non-cancer diagnosis and the demographic data. So that's what we're asked to submit from organizations. So we have a small number of KPIs. Around this time as well, Claudia Bauswein from Germany was the lead author on the AIIHPC white paper on outcome measurement. And it said that we should be measuring outcomes that allow for national and international comparisons. And what they're really talking about there is benchmarking. So overall, I felt that we had a small number of national KPIs. We had a large number of comprehensive symptom and quality of life tools. We had no agreed outcome measures implemented. We had no quality assurance framework really as a result, and we didn't have any IT platform or a view to getting an IT platform that could support this even if we had. So I felt in some way that we needed to kind of tie this together in some sort of a structure, a kind of a framework in Ireland. So what I did was, what we have, this is what I had back in my mind at that stage, and I still kind of think of it like this today, is what we have in this country is we have a resource commissioner. So that's the person who gives the money. And in this country, that's predominantly the HSE, and they have a funding relationship with the service provider. So that's the organizations, that's really us. And we're tasked with ensuring that we have the right structures in place and that we have the right quality and governance implemented. And so we have to engage with clinical quality assurance, and that's all the audits and the data and the kind of data collection and analysis that we do on a daily, a weekly, and a monthly basis and a yearly basis. So the clinical quality assurance really gleans most of its information from the clinical team. And the clinical team implements the processes of care to achieve patient outcomes. So that's the basic framework. Now, if you look at the left-hand side of this diagram, the national quality standards like HICPA standards or the HSE, these liaise and feed back in a sort of a triangulated manner to the resource commissioner and the service provider. The processes of care down the bottom in the red there, they both inform and are measured by the KPIs. Remember, processes of care or processes are KPIs. So they feed back to the clinical team directly, to the clinical quality assurance framework or team in the organization, and the national quality standards ultimately as well. Now, comprehensive validated tools, these are the gold standard of assessment and they can't be replaced. And there's such a lengthy intervention really in a way, and many of them, that they're almost like a therapeutic intervention on their own. And these very much feed back to the processes of care. Now, patient outcomes are measured by outcome measures, or should be measured by outcome measures, especially patient-reported outcome measures. Now, classically, these are more simple measures that are measured more frequently, and they can serve to flag who needs to have more in-depth analysis or in-depth assessment, often with more comprehensive validated tools. And they all feed back to the processes of care. Now, if you look at this diagram, we have national quality standards. We have some KPIs, not many, but we probably need some more good ones. We have many comprehensive validated tools out there. But the one thing that we don't have are any agreed or implemented outcome measures in this country. So we're missing a large part of this framework. Now, since my catastrophic attempt to implement the Edmonton Symptom Assessment Scale in the unit, I've been searching for a kind of a simple outcome measure that we could use within our unit. So I remember coming across this article by Kathy Eager from Australia, where she described a case mix model from the Palliative Care Outcomes Collaboration. It seemed quite simple to me, it seemed quite easy, and it was generating good literature. So this is actually the article that I read. And what the Australian case mix classification is, it's an approach to classify patient complexity based on the phase of illness, the functional status, the symptom scores, the psychological and family distress. And it takes about 30 seconds in the unit to actually document this down on the actual sheet. Now they also actually advocate the ESAS, or the Symptom Assessment Scale. So what we have is we have 5 phases of illness: stable, unstable, deteriorating, terminal, bereaved. Stable is where the patient is stable. Unstable is where there's a sudden and unexpected deterioration of the patient's clinical status requiring an urgent intervention or change in the care plan. The deteriorating phase is where there's a more gradual and expected decline in the patient's clinical status, not requiring an urgent intervention or change in the care plan. The terminal phase is within the last few days of life, and the bereaved phase is afterwards, where the family needs support. The Palliative Care Problem Severity Score. So this is a patient or proxy rated score, and it measures pain, other symptoms, psychological and spiritual distress, and family and care distress. And that's measured from 0 to 3, so the overall score is out of 12. Now, clearly, this is not an in-depth analysis of any one of these things, but it's a useful prompting tool that we can use. Now, it's scored daily, and it's scored at phase change as well. And it's now advocated by the PCOC in Australia for routine screening of palliative care patients. Now, functional assessment tools, there's 2 of them that are used as part of this framework: the Resource Utilization Group, Activities of Daily Living, and the Australian Karnofsky's Performance Scale. Now, the Australian Modified Karnofsky's Performance Scale measures the patient's ability to function from 0 to 100%. So it's very like the Palliative Care Problems, Palliative Performance Scale. The Resource Utilization Group, Activities of Daily Living, measures the patient's actual performance in relation to 4 of the core elements of activities of daily living. So bed mobility, toileting, transfer, and eating. And then there's the Palliative Care Symptom Assessment Scale, which is now becoming quite validated. And this is a 7-item patient-rated scale plus one other symptom. So it measures difficulty sleeping, appetite problems, nausea, bowel problems, breathing problems, fatigue, pain, and one other nominated symptom from the patient. Now, what it does is it doesn't measure the severity of these symptoms. It measures the patient's actual distress from them from 0 to 10. So this is a very patient-focused tool. So this is what the actual assessment response framework looks like. It's kept at bedside and it's scored daily and at phase change. So I decided to try it. Well, actually, I decided to try a little bit of it as a kind of a taster to see how it would work here in my organization in Milford. So back in 2015, in Milford, we had restructured our daycare towards a therapeutic rehabilitative model of specialist palliative care in the daycare setting. And I wanted to actually see if the model was working for patients. So I said, let's use one of the PCOC measures plus some other simple tools that are validated. So I measured these before and after the therapeutic intervention. Okay, so after the 8-week cycle, what we found was that 70% of the patients actually had an improvement in the Edmonton Symptom Assessment Scale scores, 53% of an improvement in the functional assessment scores, 56 improved in the quality of life scores, and the palliative care problem severity score improved in 58%. So this was very interesting for me because it was the first time I actually saw that we could actually use these simple measures to demonstrate the quality of the model of care that we are providing and the benefits for patients. And also, for me, it was interesting to see that the palliative care problem severity score behaved in a similar manner to the other more established and validated tools. Around this time, David Currow also produced this, what I think now is a real landmark study in Australia, where it looked at 20,000 patients over a 3-year period, around 30,000 episodes of care. And it looked at the patient's phase, the symptom assessment scale scores, and the palliative care problem severity score. So I'm just going to read the conclusion of this article. It said, for both patient and clinician reported outcomes, there were statistically significant improvements in all domains over the 3-year period at a service level, with the exception of pain. And they're looking at pain now, why that didn't improve as well as the other scores. What was very interesting about this article is that this was the first large-scale study in palliative care that demonstrated that centralized bedside collected outcome data with strong IT support as part of a national quality improvement framework progressively improved patient care over time. And that quality framework is called the Palliative Care Outcomes Collaboration, or PCOC framework. So that really was, I think, a landmark study. So around this time, calls were out for the senior fellowship in palliative medicine, and myself, and this is with UCD Trinity College in Harold's Cross. So myself and Brian Creedon from Waterford, we had a chat, and we both thought that it might be interesting to do this in relation to quality and outcome measures. So we actually approached Professor Declan Walsh and discussed our proposal with him. And we submitted our application, and we were successful. So we headed over to the Innovation Campus in Wollongong in Australia, and over to Professor Kathy Eager over there, who's head of the Australian Health Services and Research Institute, and also head of PCOC over there in Wollongong. Now, the purpose of PCOC is to drive continuous quality improvement. That's why it exists. And it does this by giving outcome information to clinicians and also to local, state, and national providers of palliative care. So what it does is it has information on over 250,000 patients in this very large longitudinal database, and it performs all sorts of research on this and also assesses the effectiveness of palliative care. So the whole philosophy and sort of motto of the Australian Health Services and Research Institute and PCOC is that patient outcomes drive service development. So what they do is a kind of a consistent root cause analysis from outcomes. Now, this is done in a very non-punitive way. It's positive, it's upbeat, it's proactive, it's supportive. If the outcomes are off, they look at the processes and they implement quality improvement projects, and they have national quality improvement facilitators or QIFs or IFs to help organizations with this if they want it. This is called the PCOC cycle. And they have regular conferences and webinars and benchmarking workshops, all focusing on trying to improve quality. And all the data that are at these things are totally confidential. They also have a whopping IT platform, a massive IT platform, the likes you see in the Starship Enterprise. And we visited centres when we were over there. They're actually collecting this data and submitting it to this IT platform. So Rabina Hospital on the Gold Coast, St. Vincent's Hospital in Melbourne, Melbourne Hospices, which is very, very beautiful, Wollongong Hospital, and St. George's Hospital in Sydney. So what they have bedside, and they call these over there quite interestingly, the palliative care vital signs. So these are nursing, doctor, and MDT documented. They're rated once daily and at phase change. And the data is entered either daily or weekly into the PAL Center platform, which is then uploaded to PCOC. And then PCOC generate these reports that look at how the organization is performing in relation to the 20 PCOC benchmarks that focus on the timeliness of care, the responsiveness of care, and also symptom control. Now, if you look at the summary poster on the left-hand side, you can see all the green there on the left, and that's where the organization is meeting the actual national benchmarks there in Australia. The orange on the poster is where the organization is approaching the standard or the benchmark. And you can see they give some demographic data as well. On the right-hand side is just one of the pages of the very large and comprehensive overall in-depth report that you get as well, but I certainly won't be going into that today. So I asked myself the question, could we do this in Ireland? And I said, absolutely we could, but the one problem we had is that we didn't have an IT platform to support this, nor did we have any view to getting an IT platform that would support this. So I did what any good Irish guy would do in this situation. Myself and Brian put our arm around Kathy and we had a good chat. And we asked her nicely, could we submit data from Limerick and Waterford as satellites of Australia? And she said yes. She said that they would run our data and we could use their IT platform, their health economists, their statisticians, and we could call it, if we wanted, PCOC in Ireland or PCOC I. Essentially what it is a PCOC of Australia. Sorry, it's a satellite of PCOC Australia. And what they would do then is they would benchmark us internationally and nationally. And initially in the kind of the trial period to see if it worked, it would be free for us. And then when it becomes established, there'd be a small cost recovery licensing fee. So really at that stage, PCOC Ireland was sort of informally born between Milford Care Centre in Limerick and Southeast Palliative Care in Waterford. I was very aware of this though. I couldn't forget my catastrophic failure of implementing a symptom assessment tool before. So this time I very much wanted to focus on doing it right and on change management. Now, before I'd actually studied and I'd actually written about the Amicus change management framework, and I had this very much in my mind, and I kind of followed this process mentally throughout the whole process and still do. So I ensure that the right change foundations are in place and the right change levers are in place. I won't go into this today because it's another talk entirely. But the most important thing is that I made sure that I assembled the right implementation team. And that's a team that were interested in and enthusiastic, had the right skill sets and indeed skills mixed throughout the team. And were self-starters and have a track record of driving projects through. So that's Martina O'Reilly, Jacinta Kelly, Fargo Toomey, Siobhan Coffey, and Brian Creed. And more recently, we've been very lucky to have Dr. Norma O'Leary from Our Lady's Hospice actually joined the team. So anything that's been achieved with PCOC nationally is down to these people in this team. So we started collecting data and we started, presenting this data at, at triage meetings, at MDTMs, at handovers, all the time to allow the language to pervade through the organization. So the first kind of stumbling block that we sort of came across was, could we actually upload this data onto the PCOC platform from Ireland? So we uploaded 1,000 patients' outcomes with no difficulty at all. in a pseudonymized manner onto the PalCenter platform, and it worked very easily. It's GDPR compliant. We have an enhanced data privacy impact assessment completed with Australia. So that was the first kind of hurdle that we got over. It was very important to me that we also generated our own research as we went along, because I wanted to develop the evidence base in Ireland. So in 2020, we published an article where we used the PCOC tools to demonstrate significant, progressive, and linear improvements in pain, other symptoms, psychological and spiritual and family and care distress after admission to a specialist palliative care unit. And we received an award for the best European research article in the Journal of Palliative Medicine in 2020, presented at the AIIHPC. And this was very reassuring for me, because it reflected that the international community was looking at this and kind of was acknowledging the benefit of this type of work. More recently, in the month just past, we produced this very orange-looking publication in the International Journal of Palliative Nursing, titled "The Association Between Phase of Illness and Resource Utilization, a Potential Model for Demonstrating Clinical Efficiency." And this is where we use PCOC tools to demonstrate the flexibility and responsiveness of nursing care based on patient need in the specialist palliative care unit, and also demonstrate the clinical efficiency of nursing activities within the unit. Now, we may all know this intuitively, but it's a very different thing to be able to prove this under peer review, which is what we were able to do. Now, very surprisingly to me during this time, colleagues from other services started coming up to us conferences, and they started phoning us, and they were asking us, could we try this? So we asked PCOC, and they said yes, but they advised us, because they're over in Australia, they advised that Milford will act as the satellite liaison centre for PCOC in Ireland. So we would be implementing the induction, the training, the education, the workshops, the conferences, the webinars, the quarterly e-zine, the PCOC Champions Network, and we would provide ongoing support for services in Ireland. So we were a bit daunted by all this, but we said, we'd certainly try. Now, currently in Ireland, PCOC is implemented to varying degrees across these services. Some are only starting out, and some are very advanced. We have 6 services that are actually now submitting data internationally and getting multiple iterations of benchmarking. So that's where PCOC is at the moment in Ireland. So going back to the diagram that I went through before with you, I would hope that maybe the PCOC suite of measures could fulfill some of this role within the framework. So we have a few frequently asked questions that I'll just go through with you now about PCOC. The first one is this framework validated? So the answer is, well, yes, it is. All the elements of PCOC have been validated to varying levels, and the overall framework has been validated through population level studies. The papers for this are actually, if people want them, I have them on a zip file. I call it the PCOC repository. I'm very happy to send them to people. Anyone who wants them to just email me. The second question is this only a pilot in one service? Well, hopefully I'll have shown to you by now that no, it's not. It initially was a pilot in 2 services, but now it's much more extensive than that. Plus, it's been extensively implemented in Australia over the last 15 years with strong research and publications. It's implemented in New Zealand. It's implemented in varying degrees in Taiwan and Singapore. Yesterday, I heard that there's a task group going to China to start to implement it as well. Germany and Canada are exploring it and implementing it to certain degrees, and they're actually publishing research on it. And as I said, now it's widely being implemented in Ireland. Is this national policy, and is it mandatory? No, it's voluntary. It's completely voluntary. It has been national policy since 2001 in this country, thanks to the National Advisory Committee report, that we should collect outcome measures. And it's also national policy through HICRA and the HSE. But PCOC itself isn't mandatory. It can actually help with those things if people wanted to, but no, PCOC is not mandatory. It's totally voluntary. Will it be tied to funding? No, well, it's not policy, so it can't be. And anyway, they're not national quality standards. If you remember back to that diagram, those are process measures. These are outcome benchmark measures, so they can't be tied to funding. And anyway, in Ireland, the available key performance indicators that are there, the 5 that I went through with you earlier on, they haven't been associated with funding either. So the answer is no. Confidentiality. Will anyone see our information? No, it's organizational information. It's between them and PCOC. No one else has access to that. What the organization themselves chooses to do with this information is totally up to themselves. What we found in Australia and in other places is that organizations are actually quite proud of the fact that they're engaging with international benchmarking, and they put these kind of posters up around the organization and talk about what they're doing internationally. And even at the national benchmarking workshops, services are actually assigned a number, and those numbers are scrambled prior to the workshop. So no one knows whose information is being actually discussed except for the service themselves. It can only be used in specialist units. Is that right? The answer is no. It's used in all settings of care. It's used in hospitals, IPUs, community and daycare settings, internationally and here in Ireland. Does it medicalize palliative care with only nurses and doctors completing the scoring? Oh no, it doesn't, because all members of the MDT fill in the PCOC scores in Milford, as in Australia. Physios, OTs, social workers also see the benefits of PCOC and also score PCOC. How does collecting this data actually improve patient care? Well, firstly, from a quality improvement perspective, if an organization is collecting this data relative to the benchmarks, it's actually engaging in continuous quality improvement through the framework. And we know from David Curl's study back in 2015 that this progressively improves patient care over time. Secondly, from a prompting perspective, PCOC scores prompt teams as to who need more in-depth assessment, and it guides the MDT referral. So it's very helpful that way, but it's not meant to be a comprehensive tool in any way or replace the validated clinical assessment tools. And finally, from a communication perspective, what we found here in Milford and what other organizations all feed back to us is that communications within teams is much more focused, as this kind of PCOC language pervades the organizations at the triage meetings, at the handovers, at the MDTMs, even on telephone contacts. And they highlight the most pressing issues for patients very clearly, usually right at the start of a clinical presentation. Is it burdensome for patients or staff? I don't think so. Proxy scoring can be used for very sick patients. That's part of the framework. We did a SAS study, a symptom assessment scale study here in Milford in 2022, and it's at the submission stage at the moment. And it actually found that patients liked being asked about their symptoms. And Siobhan Coffey, our quality improvement facilitator here, presented this study at the AIIHPC in poster format. And some of the comments from patients were quite interesting. One said, I find it easy to score. I find it helpful all around. I feel I am getting a say. Another patient said, I am more involved in my care. My life has changed dramatically. Nothing has worked, radiotherapy or chemotherapy, until now. I feel very involved. Now for staff, we certainly haven't had any feedback that it's burdensome for staff to fill in. It takes about 30 seconds for staff to fill in on the framework within the unit. In the community, it takes about a minute because they have to sit at a computer when they get back, and they have to open and shut the PAL Center actual platform, but that's less than a minute. And we timed that. Is it just putting numbers on patients and putting them in boxes? Well, absolutely not. It's only a clinical aid. It's there to help. It doesn't define case mix. It just concisely describes case mix. So it helps the MDT to assess, prompt, and communicate. But our own patient interactions and our patient care and our professionalism, that can never be replaced with any tool. So what does the future hold for PCOC in Ireland? Well, we had a PCOC webinar just in May 2022 there, which was really a great success. We're going to do a PCOC conference and workshop here in Ireland in April 2023 with some great international speakers coming, like David Curl, Kathy Eager, Barb Davison, and others as well. So it's going to be a very big conference, and we'd love people to see some of you people there too. New sites are currently submitting data, and we want to continue to give them ongoing support with education and ongoing help with implementation and analysis of the reports that they get back from PCOC, and also help with their data uploads and submission. We're currently at the final stage of developing our own national governance structure, which is something that I never thought we'd have to do, because I thought PCOC would only be in one or two services, but now it's big enough that I feel that it's important we do it, so that we're all agreeing that we're all going in the right direction, and that we're all ensuring that we're having best practice and adhering to good standards. We want to continue to publish research. We want to continue that evidence base in Ireland through publication. And we've just received ethical approval for multi-site research in relation to the symptom assessment scale. And we also want to engage and continue to engage in supporting organizations with quality improvement initiatives. So if you're going back to this diagram again, I would hope that PCOC Ireland will be able to in some way fulfill some of this role within our own national quality framework. So just going back to what Steve Jobs said, he said, you can't connect the dots looking forward, you can only connect them looking backwards. So you have to trust that the dots will somehow connect in your future. I feel that I'm currently still connecting the dots with all of this, but I hope that in time I'll be able to look back and all of this will make sense. So thank you very much.